My name is Valeria Esparza, and I'm a medical student at the University of Illinois College of Medicine. Today, I'm going to present the clinical case Staphylococcus Pseudintermedius Bacteremia in shock. I work closely with Dr. Javier Jimenez and Dr. Brian Wagoner from the University of Illinois Hospital and Health Sciences System. Staphylococcus pseudintermedius is a common zoonotic flora and pathogen in canines, known to cause skin and soft tissue infections. An emerging methicillin-resistant strain has become a significant veterinary concern. Staph pseudintermedius may be misdiagnosed as Staphylococcus aureus depending on lab capabilities and may be more common than known. Although Staph pseudintermedius infections have been noted in humans, no reports of bacteremia with shock have been documented. This is the case of a 78-year-old male with a history of orthotropic liver transplant on cyclosporin, chronic kidney disease, and photosensitivity dermatitis who presented for worsening rash and pruritus associated with fatigue. On admission, he was afebrile and hemodynamically stable. On physical exam, the patient's skin was erythematous from head to knees and dry with excoriations from the head to the neck all the way to the chest. Here we can appreciate a picture of the patient's forearm on day 2 of admission. Next to it is a picture of the patient's neck as well. Laboratory findings on admission were remarkable for elevated creatinine at 2.44 milligrams per deciliter. Based on chart review, the patient's baseline was determined to be 1.6 milligrams per deciliter. It was also remarkable for a potassium of 7.1. The patient was admitted for acute kidney injury and hyperkalemia, which improved significantly with fluid resuscitation. On the 3rd morning of admission, the patient became septic and hemodynamically unstable with a temperature of 39.4 degrees Celsius and a blood pressure of 70/40. Vancomycin and Zosyn were initiated as skin flora was a concern given the patient's poor integument, and clindamycin was added for toxic shock. Blood cultures were sent due to concern for bacteremia as well as a chest x-ray, which was unremarkable. Rapid fluid resuscitation was insufficient to maintain hemodynamic stability, and the patient was transferred to ICU and required 3 doses of vasopressors to maintain hemodynamic stability. Blood cultures sent at the beginning of his hospital course speciated Staphylococcus pseudintermedius, which was susceptible to cephalosporins. Antibiotic regimen was then reduced to cefazolin, and the patient returned to the general floor the following day. There were some key findings on the history which were relevant to this case. When infectious disease was consulted after the patient returned to the general floor from the ICU, he endorsed he had been having night sweats and chills for 3 weeks. He also endorsed having contact with his pet dog, which suffered from multiple skin lesions and a spinal abscess that impaired its ability to walk and caused fecal incontinence. The patient also endorsed there were less than optimal hygienic conditions at home. It was then determined that there was a correlation between canine disease course and the patient's worsening rash. After stabilization of electrolyte abnormalities, the patient successfully completed 14 days of cefazolin antibiotic regimen and recovered favorably. This case is relevant because doctor-human transmission of Staph pseudintermedius is poorly understood and likely underrecognized. Accurate identification of Staph pseudintermedius is essential given evidence of pathogenic potential and continuous rise in methicillin resistance with ability of transference among Staphylococcus species. In humans, cephalexin and clindamycin have been successfully used to treat soft tissue infections and IV vancomycin for bacteremia. Considering that pet dogs are very common, proper identification of this pathogen is necessary to guide antibiotic treatment, prevent invasive disease, and avoid further rise in methicillin resistance. Thank you.